Good afternoon and welcome to today's Ask the Expert webinar on treating staff, family and friends. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today and pay my respects to the elders past and present. I extend my respect to the Aboriginal or Torres Strait Islander people who are present today. At Avant, we're delighted to continuously support our members with resources like this webinar. Of course, we have lots of additional information that can be found on our website and the Avant Learning Centre. As I have mentioned, with so many people joining us this evening, we'll have to keep you all on mute, unfortunately, but please send any comments or questions to our panelists via the chat function, which can be found at the bottom of your screen on your toolbar. Although our advice here today is general advice, if you are an Avant member, we invite you to contact our medico-legal advisory service for any specific questions that you might have. At the conclusion of this webinar, you'll be asked to complete a short survey. We really appreciate if you could take a few minutes to give us your feedback. So with that, I'd like to hand over to your presenters for this evening. Georgie Haysom is a solicitor and the head of Avant's Advocacy, Education and Research team. Jack is an advanced trainee in emergency medicine and works as our doctor in training medical advisor at Avant. Thanks guys, over to you, Georgie.
Great, thank you very much, Michaela, and thanks to everybody for joining us. Because we're doing this by Zoom, I just need to give you a bit of a warning, which is my dogs are barking a bit, so I'm hoping that they will stop, so apologies. Otherwise, I'll switch over to Jack quickly if they start to bark. All right, so it's fantastic that you're joining us this evening in this webinar. I'm going to start with a story. It involves Sebastian. Sebastian was 6 years old at the time that he died. He had mild flu-like symptoms for 3 or 4 days before that, and he had developed a rash. He went on a social visit with his father, who was a registered nurse, to the hospital where his father worked. And while he was there with his dad's colleague said, look, I reckon you should probably get Sebastian seen to. He's not looking great. Just get him checked out. So what they did was to ask the emergency department locum, who'd only really just started at the hospital, to see Sebastian. It was done informally. It wasn't triaged. There were no notes made, no discharge plan at the time. So the emergency doctor concluded that he had a viral illness. He got sicker the next day. He was then seen at the emergency department formally, but his care was really impacted by the lack of formal triage and consultation that happened the day before. Ultimately, though, Sebastian died due to sepsis superimposed on influenza A. In the inquest that followed, the coroner noted that the request for the locum to see Sebastian put the doctor in a really difficult position for many reasons. So the colleagues expected that the doctor would drop everything and do the consultation because it was expected to be quick. Just have a quick look at Sebastian. Colleagues are often forced by other colleagues to have the consultation when the doctor who's asked to see the colleague or the family member doesn't really want to do it. And so the history taking is brief. And the colleague may also think that they know the cause of the illness and may give a history that is directed towards what they expect. So that sort of biases, I guess, the person who's seeing them. So we're going to have a look at this today. Jack, I think you're going to say something now about why. Why is this a problem? What is the problem with seeing family and friends? Just to give it a hint to why we're talking about this.
Yeah, thanks, Georgie. So I think that's a really powerful scenario. And I think one of the key things that Georgie's already raised there is this idea that these are awkward situations to be put in. And especially as a kind of a doctor in training or a junior doctor, you don't necessarily have the gravitas of 30 years of experience under your belt. And it feels a bit harder to say no in these situations often. So I think the first thing I want to acknowledge is when it's happened to me as an emergency doctor, doctor in training, I find it an awkward and quite difficult situation to be in. But the reason this isn't ideal to be treating patients like this is that you don't have objectivity. If you're being asked to do it as a favor, it's a friend or colleague or family member, you can't have the same objective approach to the caregiving that you would if it was a normal doctor-patient relationship. The other thing is you do end up with discontinuity of care. And as you saw from that scenario, there was a lack of proper follow-up, and when the patient represented, it wasn't clear what had happened before. So there is a real risk of introducing discontinuity of care when you're doing these kind of corridor consultations. And ultimately, this had a terrible outcome for the patient, the child, but also will have had a negative outcome for the doctor who would have been involved in the coroners and everything that goes with that. So that I think one of the big take homes that we'll come back to at the very end of this presentation is this idea that doing this kind of prescribing is risky for you as the doctor, but also really risky for the patients in some circumstances.
Thanks, Jack. So I did want to say thank you very much for sending in questions beforehand, because that's really helped us to make sure that the content deals with the questions you've asked. So we'll go through them. We'll try and answer those questions as we go through, and as we also said, put some things into the chat function. So we'll get to them as we go through. So thank you. All right, so what I thought we'd do is just start with some of our data. So if we can flick to the next slide, perfect, there it is. So what we did was have a look at the top 3 most common types of non-sexual boundary violations from our claims data. So we code all of our data and we can have a look at it and go back and look at what it says. So you'll see there that treating family members and friends is one of the top 3 there. And you can see there with the dark blue line that those cases where there's an allegation of treating family members or close friends, they're the ones most likely to be substantiated. So what that means is that the majority of doctors in these cases, 73% of doctors in these cases, were likely to have breached their expected professional standards. So we've got a poll question for you to start with. We'll just put that up, and we want to just get an idea from you about whether you prescribe for family members or friends. And while we're waiting for those results and while you're all voting, Jack, what's the experience of most doctors, particularly when doctors start out in practice?
I expect almost every single one of you listening will have been in a situation where either you or one of your colleagues will have been put in a position of being asked to do a prescription by a family, friend, or colleague. And I remember when I was starting out as an intern, I was in the UK as an intern and a resident. And I remember feeling that kind of I'd done my medical school. This was my time to be a real doctor. And so when put in that position, put and asked to do prescriptions, I felt quite reluctant to say no, because I felt like it would undermine the kind of the knowledge I'd accumulated at medical school, in this sense that I was now a doctor. So I felt like a sense of myself wanting to do it to kind of prove myself. And I wonder whether that resonates with some of you as interns and residents who are being approached by family members, and you finally feel like you can be useful, and it makes it harder to say no.
So what, if we just have a look at the results, yeah, there we go, fantastic. So that's interesting, Jack. 57% of you have said no, and 43% of you have said yes. Okay, great. So I'm assuming that, well, I don't know, I can't make assumptions. Let's not make assumptions as to why people have said no and why people have said yes. So I think that's good. We've said before that people shouldn't be prescribing for family and friends for various reasons. But where does this come from? It's not illegal, but it's in the code of conduct, Jack.
Yeah, absolutely. I'm interested actually to see so many of you say no, because I've certainly been put in a situation before where I've ended up prescribing for family, friends, or colleagues, and so I think a lot of you, I'm impressed or surprised that a lot of you have said no, and I'm not at all judgmental of those of you who have said yes, because it's so easy to do, and we'll come on to discuss that in a minute. But as Georgie said, there are some clear guidelines there in the code of conduct as to what is the standard when being asked to prescribe by family, friends, or colleagues. So you're being advised, if you have a close personal relationship with someone, to avoid providing medical care because of a lack of objectivity, the possible discontinuity of care, and the risks to the patient and doctor. All of those 3 things we talked about in relation to that first scenario. And in particular, in the code of conduct, it refers to Schedule 8 medications, psychotropic medications and drug dependence, and elective surgery as those things that you must not do for people who you have a close relationship. It does give you a caveat that in some situations, this may be unavoidable. And we're going to go on and look at that in a bit more detail in a minute about those situations where you would be excused, if not obliged, to provide care to someone who you're close family friends with or a colleague in an emergency kind of situation. But we'll come on and talk about that. But that's the kind of framework by which you should be basing your standard, the code of conduct there.
Thanks, Jack. And it's important to remember that some of the colleges have their own codes of conduct in addition to the code of good medical practice that applies to all practitioners. So make sure you check out what your college's position might be on this. For example, surgeons, the College of Surgeons specifically say it's inappropriate to perform operative procedures on on family members, and they also say it's inappropriate to write medical certificates. So that's an important thing. Check out what your college guidelines say. So we're going to look at some case scenarios now. They're based generally on a kind of compilation of real cases, but the names have been changed. So let's have a look at Phil and Sarah. So Phil and Sarah are friends who regularly play tennis together. Sarah's a GP. Phil owns his own business. He takes Nexium intermittently for heartburn, but he's otherwise quite well. He doesn't have a regular GP, but he likes to get the script for Nexium because it's cheaper than getting it over the counter. He's about to go overseas on a work trip to source some suppliers, and this was pre-COVID when you're allowed to travel overseas, and he wants to get a supply of Nexium for his trip. Doesn't have time to arrange an appointment with anybody. As I said, he doesn't have a regular GP, so he asks Sarah for a script. So I don't know, Jack, is it okay to prescribe something that you might otherwise get over the counter?
It feels like it, doesn't it, Georgie? It feels like Nexium, it's a low-risk medication. It's available commonly. It's for the treatment of his heartburn, which it sounds like is quite established, and something which is in itself probably not something which is going to escalate rapidly. So it feels like it's something which would be quite easy to do a script for. And I mean, it wouldn't be unreasonable, I think, if some people in the audience listening were thinking, oh yeah, I might do that.
Yeah, it's an interesting one, actually. And the other thing that this might raise is the issue of how close a friend Phil is. So we don't know, they play tennis together regularly, but how close does the person need to be? Because some people, might say, oh, if they're a really close family friend, then you shouldn't be prescribing for them. But then someone who's a bit more removed that you might only see once in a while, maybe that's okay. I don't know, Jack, whether you have any thoughts about that.
Yeah, I think so. I think it does depend a bit on the relationship. And I think that my mind would be twigging no to some other things. For example, how do we know this is heartburn, simple heartburn? We all know those cases of a heart attack or acute coronary syndrome, which actually manifests as a heartburn. How do we know he's not having some angina when he's playing tennis? And the other thing which would be clicking for me is, what if I say yes now? Is that setting a precedent for anyone else on the court who I'm playing with, or for him down the line?
And does it matter what sort of medication it is?
Yeah, absolutely. I mean, I think if he came to you and said, oh, I'd like a script for some endone, every single one of us would say, hang on a minute, that's not quite right. I'm not doing that. Whereas with Nexium, it seems much tamer. It seems like something you might do. So there is that question there. Where is there a risk assessment to this, which makes you think Nexium is more acceptable than endone would be?
Now, that's a good place to answer one of the questions that we had beforehand and that we've had on the chat as well, which is, what's the laws around prescribing outside hospital as an intern? So, you've got a prescriber number, but can you prescribe outside the hospital? What would be your thoughts on that, Jack?
So I think it's tempting. As I said, like when you're an intern, you're finally fully fledged doctor and you want to be able to kind of show that you can use those skills. But I think the fact that you've got a prescriber number and you can do prescriptions doesn't mean that you necessarily should. And I think probably even more so as an intern or a junior doctor, you don't quite have that background of experience to kind of pull out red flags or nuances in it, which might alert you otherwise. So I think you still have to apply the same kind of thought processes here and still reflect back on that code of conduct. And if possible, err on the side of caution and not be prescribing.
And I should mention at this point that there have been cases involving interns who have gotten themselves into difficulty before the tribunal for prescribing to their family and friends. There was a case which I'll talk about a little bit more later, but certainly it was an intern who just started who decided that they would prescribe some medication for their girlfriend for a urinary tract infection. There were a couple of instances of this actually with a few different girlfriends, but nevertheless, that wasn't very sensible. And I think ultimately it was one of the girlfriends actually, who complained about that doctor. But that doctor, when they turned up as an intern, felt that they had enough knowledge to be able to prescribe this. And as we'll see a bit later when I talk about that case in more detail, that wasn't in fact the case. So we might keep moving on to the next part of the story. So in this case, Sarah does write a script for Phil. He goes overseas on his trip, but it doesn't go so well. And the next time that they meet with each other, he's under quite a lot of stress. So his business isn't going so well. He says he's not sleeping very well, and he's having difficulty concentrating at work. So he asks Sarah, now remember, Sarah's already given him the Nexium. He asks Sarah, look, could you just prescribe me something to help me sleep? Just to tie him over for a couple of weeks. And Sarah says, well, you know, you really should go and see a GP. And he said, look, I promise I'll go and make an appointment with a GP. So Jack, what do you think about this now?
Yeah, this is the problem, isn't it? So that's so whilst Nexium, you might make a risk assessment and say, really, Nexium's unlikely to get anyone into trouble, either you as the doctor or the patient in their own health. But you've set up a precedent here. And now it's much harder to say, oh, I don't prescribe for friends or family, because you already have. And so now you're trying to draw a line in this gray area, whereas I was happy to prescribe for Nexium, but I'm not happy to prescribe you a benzo to help you sleep better. And so it makes your argument and your kind of position harder when it comes to saying no. So I think that's the first thing. The second thing is we're clearly seeing a pattern of behavior here with Phil. So he's beginning to use his tennis partner as his GP. And this could just become a slippery slope where actually all his care needs now get directed to his tennis partner. And finally, you've got to think about this not sleeping in a slightly wider context. Does this need a bit more of a holistic history taking? Do we need to examine Phil? Do we need to talk to Phil about his mood, his other kind of features of depression, if there are some? Do we need to worry about that Phil is much more unwell than he's letting on and is kind of self-harming? And those kind of, once you start straying into those kind of history questions, it's not something which is going to happen on the tennis court. So you're probably not going to do them. But there's some questions you'd feel much more comfortable doing if this was a patient of yours in the emergency department or in your GP practice. So you're actually foreshortening and doing a very poor history and assessment of Phil because of social etiquette, but actually at the detriment to Phil here, because he might need more help than he's letting on. And the drug itself, I mean, benzos are S4, some of them S4Ds, and I would feel much more uncomfortable prescribing what is essentially a drug of dependence to someone outside of a very clinical setting, as opposed to Nexium.
Yeah, thanks, Jack. And it's interesting because we have seen a lot of these cases where doctors start small, you get the small request, and then it just kind of snowballs. I'll just talk about a couple of, so the slide that's up there refers to those things that Jack mentioned too, but a couple of interesting cases that happened. So often doctors will get themselves into this situation because they genuinely want to help their family members. A lot of things we hear is, you know, I wasn't happy with the care that my family member was getting, and I thought I could do better. And the other thing we hear is just, well, I was just helping them by prescribing them with a repeat for their medication that they've been on. And that does sometimes start this slippery slope. So there was a case of a doctor who had a couple of daughters, and one of her daughters had some psychiatric issues and was being treated by a psychiatrist and getting medication. But that doctor decided that she would help by prescribing some of the meds for the daughter. She didn't tell the treating psychiatrist what she was doing. She also provided a medical certificate for the daughter, a Centrelink certificate. So where she had to sign off as the treating doctor, and she then provided some misleading information on the certificate, which was around the fact that she was the treating doctor. But she was there with a genuine desire to help her family member, but then it's all snowballed and got her into trouble. And she was sanctioned in the courts for doing that. So that's what can happen in the situation.
That's a good example of objectivity there, Georgie, I think, because I think we all listen on and think falsifying a medical certificate is crazy, and who would do that? But in a situation where you're looking after a family member and there's a lot of emotion involved, it's very easy to lose perspective of what's unprofessional and what's not acceptable when you're in that moment. And that's sometimes only easy to see when you're standing outside the picture and looking in. And that lack of objectivity is a big reason why this is a difficult thing to do.
Yeah, absolutely. And then another case example I wanted to mention was the case of the doctor who was also prescribing a bunch of S4 medications and also didn't refer the patient for an objective assessment. But in that case, there was no suggestion that the medication was inappropriate or in excessive quantities. So you may well be actually prescribing appropriately, but that can still get you into difficulty. So I wanted to refer to that as well. It's not about whether it's appropriate clinically, it's about whether it's appropriate professionally. So we might move on to the next one, if we can. All right. So just moving on to the next situation, this also comes up quite a bit. And this is the situation of a nurse approaching you for a pathology form because she thinks she might have a urinary tract infection. So we've got a poll question for you. How would you normally respond to this sort of request if you're asked? And Jack, while we're waiting for that, the answers of that poll, do you have any reflections on this situation?
Yeah, again, I mean, I've been put in this situation before, and it feels again like the appropriate thing to do if she's had UTIs in the past and she knows what it feels like, and she wants to just check the organism or whether it's there. It feels like appropriate clinical management. But I think, as you've said before, Georgie, just because it's appropriate clinical management, does it mean it's appropriate professional management? I'll be interested to see what people think before we kind of had a chat about perhaps some of the issues that come up as a result of this.
Yeah, and I think this is a really good example of that issue around boundaries and where you draw the line, because I think a lot of the cases that we're talking about, both the real cases and the scenarios, is situations where those boundaries are crossed, and particularly when you've got corridor consultations, that's an issue of boundary crossing. So do we have the results there? Yes. Okie doke. So no one said yes. 58% said yes, but they need to follow up with their GP, and 42% said they just say no. So I thought I might give you a bit more detail about that case I mentioned before, and then we might talk about some other issues. So just the case that I was mentioning before where the intern got himself into difficulty, what that doctor did was, I mentioned that he had just started being an intern, and he gave his girlfriend some antibiotics for a urinary tract infection. And she went to the emergency department of the hospital on one occasion and was examined by the emergency department doctors, who decided she didn't need a blood test, but our doctor took a blood test anyway, ordered the test in the name of another doctor, and then when the results came back, wrongly interpreted the results as pancreatitis, but in fact the results were suggestive of mild gastritis. That was with one girlfriend. And then when he was working at a country hospital, he was in a relationship with another girlfriend, and he wrote scripts for, I'm not going to say these properly now, cefalexin. Yes, excellent, cefalexin and trimethoprim, without any proper clinical assessment and without creating a record. So if the nurse comes and approaches you for, to do a MSU, you haven't made a note, you haven't taken a history, and then you probably haven't created any record at all, and that might be relevant to the situation. Jack, I think there's some questions around that, the clinical questions that you might need to think about when the results come back, or even when ordering that sort of test.
Yeah, absolutely. I think one of the big issues with treating colleagues, a bit different, or medical family and friends, so anyone who's in the medical sphere, the problem is I think they often come to you with a pre-formed diagnosis. So in the situation here with your receptionist or nurse, they've come to you and said, I think I've got a UTI. And you kind of are then, especially if it was a nurse asking you that, you'd be a bit embarrassed potentially to say, are you sure it's a UTI, and questioning them. So you take that on face value and you start management for a UTI. But what if, for example, this person's got an STI, a sexually transmitted infection? Or what if they're pregnant? If that changes the way we would manage a UTI, or indeed if they've got abdominal pain and they're pregnant, it might be something much more serious altogether. So actually inquiring a bit more as to what the underlying issue might be and doing a full assessment, as you would if you were the GP or the treating doctor, is really important, and often something we wouldn't do because we're reluctant to start questioning our medical colleagues as to their diagnosis. So that's an issue I find happens when a colleague asks you for some treatment or for a script. And exactly as you said, Georgie, what happens if this gets worse? What happens if this is a resistant bug in the urine and nobody's following it up properly because it gets slightly lost in the system and you haven't made any notes, and the patient gets really unwell? Or what happens if you do make notes and someone in the practice, this person's notes are then on the practice records, and which other people might have access to, so it introduces a confidentiality issue? Or what happens if this person then gets really sick, needs a sick certificate, and then you're asked to provide the sick certificate, but you're the employer? So there's just a real quagmire of potential issues which can arise from this, which can be avoided if the patient sees their GP.
Yeah. Now, one of the questions that we get a lot, Jack, is around the rural situation. So a lot of people say, yeah, look, that's fine. You tell me not to treat people, and family and friends, all my colleagues, but I work in a rural setting and, I'm the only doctor there. That's maybe not the case of training doctors and interns and the like, but certainly some of our doctors in private practice will say, I'm the only GP in town. What do I do? So what can doctors do with that one?
It's a really good point, Georgie, and it's easy to become kind of urban-centric and think about it like you're in a massive tertiary teaching hospital. But as you say, if you're remote or rural, you might be the only doctor. Even if you're a doctor in training, you might be the only doctor around during kind of on-site or around during a nighttime. So some situations, and the code of conduct appreciates this, you might be in a situation where you have to treat a friend or colleague or someone you know well. But in that setting, there's things you can do to minimize risks. So I think a real sensible thing to do is to make sure that you're treating the person in a real clinical context. So if this is someone you know well, because you know everyone in the small town, bring them into your rooms for a consultation. Don't have the consultation in the car park of the supermarket, for example. So you're really putting in that professional boundary, which can otherwise very easily be transgressed. Make sure you're keeping really good records, and if you can, acknowledge the fact that you know this person and take account of that. And the other thing is to try and hand over care as soon as is kind of reasonable and practical. So if there is another doctor available in the next day or so who can take over care of this patient who doesn't have the same relationship with the patient, making sure that handoff of care is done as quickly and as appropriately as possible.
Because I think it's really important, as I mentioned earlier, to make those boundaries really clear. And one of the comments that one of our colleagues has made is that, the consultation, the personal finishes at the door of your consultation room, and it becomes a professional interaction. So if you are in that situation where you are the only doctor in town, then you must make those boundaries really clear and not blur them, because I think that's where you really get into trouble. So we might move to some of the questions that we received beforehand. A lot of people have asked us questions about whether they can prescribe medication for themselves, self-prescribing. Jack, short answer?
I think short answer there has to be a no.
And the long answer is that actually, a small short answer, but slightly longer, is it's actually an offence in South Australia to prescribe for yourself. So we've moved from the unethical to the illegal in South Australia, and it is also not permitted in Victoria. So there is legislation in Victoria that says you can only prescribe S4s and S8s for people other than yourself. And when I say it's illegal in South Australia, it's in relation to drugs of dependence, actually. So it's illegal for drugs of dependence in South Australia. And not permitted in Victoria for S4s as well as S8s. In South Australia, the penalty is $5,000. So it's an offence punishable by a penalty of $5,000. But in Victoria, the penalty is 100 penalty units, and the penalty and one penalty unit is $165. So that's $16,000 in Victoria that you can be potentially fined if you write a prescription in your own name. So I think that supports the short answer, doesn't it, Jack?
I think so. I think there's definite arguments for grey areas in prescribing, but I think when it comes to self-prescribing, it should be more black and white, and you should be not doing it. And I think the medical board will have a very dim view on you if they found out that you were self-prescribing.
Yes, and I think that that raises the issue as to why are you prescribing for yourself? Do you have a general practitioner? And one of the things that the Medical Board's Code of Conduct makes clear is that you really should be looking after your own health and having your own general practitioner, and you shouldn't be self-treating or self-prescribing. It's important to seek independent and objective advice. So someone's asked a question, self-prescribing even a steroid cream for a skin disease is illegal. I don't think we're saying that that's illegal. The only thing that's illegal is South Australia and Victoria for prescribing drugs of dependence, but it's unethical and looked down upon. Would you agree with that, Jack?
Yeah, so the illegality bit, I think you're saying, Georgie, is for the drugs of dependence. But as a general principle, all prescribing for yourself is a no from a professional position and would be looked on very unfavorably by the medical board.
Yes. That's correct.
I completely take your point. It seems silly. It seems silly that you couldn't prescribe yourself a hydrocortisone cream for a bit of eczema or something. That I can understand that, but the medical board is very strong on you having a GP to manage these conditions for you, and really doesn't like doctors taking their own health into their own hands, even if it seems relatively trivial. And so I think that you have that kind of basis for all your thinking when it comes to self-prescribing.
And then thinking about prescribing for family members, again, there's an issue of how do we define family? Families are getting broader and broader in their definitions. And so we've had some questions that people have asked us, well, if it's my friend's child or my uncle's, wife, how far away should that relationship be? And I think that the general guide is about how close that personal relationship is, and it is around that objectivity point. And I guess that's going to be a matter of degree for the circumstances in which you find yourself. I wanted to tell you about another case that was reported, which involved a patient or a doctor whose spouse was admitted to hospital suffering from severe pain from a medical condition that required a high level of care. The judgment doesn't outline exactly what that condition was because it's all been anonymised and de-identified to protect the family member and the doctor's name. But when the spouse went into hospital, the doctor disclosed to the hospital staff that they were the spouse's primary general practitioner. And that's what resulted in the notification to AHPRA. So it's important that it may not be the family member who makes a complaint to the medical board or to AHPRA. It may be someone completely different, so the hospital staff in this situation. And in that case, the spouse had received treatment from the doctor, the spouse, as well as regularly visiting another general practitioner. And the medical board imposed a condition on the doctor's registration that prohibited them from treating family members and others with whom they had a close personal relationship. And that doctor was, and actually it was except in emergencies, and that doctor then had to notify the medical board if they were to treat their spouse in an emergency. So that's the sort of thing that can happen. In other cases, doctors have been reprimanded. Depending on the seriousness of the case, they've also had their registration suspended for a short period of time. So you can be sanctioned quite harshly depending on the circumstances.
That's an important point, Georgie, you've made there as well, that often you feel like if you're prescribing for someone else, there's that feeling of, oh, who's going to know? Like, my friend's not going to report it. I'm not going to report it. Who's ever going to know? But actually these things, the cases that we see is not necessarily you or the person you're prescribing to who makes a complaint or lets APRA or the HCCC or someone know. It could be the pharmacist, it could be a relative of the friend or a friend of the friend who doesn't agree with it. If you're doing it in a workplace setting, it could be someone else on the ward, it could be another doctor, a nurse, a ward clerk. So anyone can make a complaint against you if they feel strongly that you're doing unprofessional behavior. So it's often difficult to just say, no one's going to know, because in the cases we do see, other people are doing the reporting.
Now, here's a good question that's come into the chat. Are we under any obligation to report GPs who are treating GPs for their first degree, who's the treating GP for their first degree family members? So this is quite a difficult situation, Jack. I don't know whether you have any thoughts. I can talk about mandatory reporting laws, but do you have any thoughts from the practical perspective?
Yeah, I mean, this is a really tricky situation, especially actually if you're a doctor in training and this is one of your supervisors, but really about any doctor, this kind of situation of calling out unprofessional behavior. And I think the first thing to do is to, as you would classically do, try and pull the doctor aside, have an informal conversation with them, saying maybe they're not aware of the issues, guiding them to the code of conduct, which makes them aware that they shouldn't be doing this. So perhaps just a bit of education and more of an informal chat and discussion, escalating perhaps to discussing with other colleagues and more senior colleagues who can have that conversation on your behalf if needed. But ultimately, Georgie, I suppose it comes down to a question of mandatory reporting, doesn't it?
Yeah, it does. And so the mandatory reporting laws are well, they are a little difficult to follow, and it is often a matter of your judgment as to whether or not you think that the conduct that you're looking at falls within the definition of notifiable conduct. So the one that we're talking about here is the aspect of notifiable conduct that which is called significant departure from accepted practice. And in those circumstances, you have a mandatory obligation to report if it's putting the public at risk of harm. And that is a matter of degree. What I should suggest to you is that if you're thinking about a mandatory report, or you're not sure about whether or not to report a colleague of yours in relation to their conduct, you need to have a look at the APRA website and the rules around mandatory reporting. It's a very high threshold, and it's all based on putting the public at risk of harm. So there's actually, just while we're at it, I may as well tell you about the other ones. So there's other situations where you need to report a colleague, and again, based around risk. There's sexual misconduct, although that's not so risk-based, that's any sexual misconduct. There is practicing whilst intoxicated with drugs or alcohol. There's putting the public at risk because of an impairment. And then there's the departure from professional standards, which I mentioned before. Now, I need to tell you, it's really high threshold. A lot of doctors are concerned about the notion of illness and going and seeing a treating doctor if they're unwell or they are suffering from a mental health condition. Then, but the laws have been changed in that regard. So whilst I raise that issue of an impairment, I don't want you to think that that shouldn't prevent you from seeking care from your GP. So it's really important that you that is not a barrier to seeking care. Illness is not an impairment. We can do a whole other webinar on mandatory reporting if that's of interest to you. If you have any queries about that and I haven't made that clear, please feel free to put that in the chat. But yeah, look at the APRA guidelines. That's the place to go.
And I think the other thing to say there, Georgie, is that's partly what your MDO is there for as well. So if you're in a situation of ambiguity where you're concerned about the need to make a mandatory notification, you can always give us a call and we can help kind of guide you through that as well.
Yeah, absolutely. So we've gone completely off topic now. So we might bring it back and move on to another scenario, which may be familiar to you. Jack, did you? Oh, I'll explain this one and then you can talk about it. So this is a registrar working in an emergency department, organises an IV for another registrar friend who arrives an hour before their shift after a big night out. The registrar sneaks the friend into the emergency. They bypass triage, much like our nurse at the beginning in the coronial inquest, bypasses the triage. A couple of hours though into his shift, he's clearly unwell and he goes home. So he calls you asking for a medical certificate to submit to the human resources department. So we have a poll question for you. I think probably this is one that you'll probably all be glad that you're anonymous in. The poll question is, have you ever been one of the two people in a scenario like this? So this is anonymous, I can assure you. So if you can answer that question. And Jack, I don't want to ask you, to expose any poor behaviour on your part, but do you have any comments on this situation?
Yeah, well, so I'm an emergency AT, and for me, this resonates because I challenge that. It's any of you have probably seen people come in and need some antiemetic or something because they're either just feeling rough or they're a bit hungover, and it's kind of something which I think as a junior doctor you're not totally unfamiliar with, and I think you might be fooling yourself if you think that that's not happened before in the hospital setting. And certainly in the emergency department, it is sometimes easy to bypass triage and come through if you're one of the doctors and just have a chat to one of your colleagues in the emergency department. So it's certainly, you can see how that situation might arise. I'd love to know what the poll shows.
Yeah, and I think they're ready. Okay, there you go.
So you guys are showing me up. I'm like, oh yeah, this happens all the time, and you're all like saying no. So that's great to see. I think it opens up, and I'm really pleased because it opens up. I think this is a particular scenario where there's a lot of bad things that can happen here. So firstly, there's the argument you shouldn't be using the hospital resources if the person's not kind of checked in and on the system. You shouldn't be treating a friend, and that kind of falls under everything we've already talked about. But there's other issues here. If this person is feeling so bad that they need some medications and a bag of fluid to get through the day, should they be at work at all? And I do think you need to be really aware of the professional, how people view you as a professional, and it would not be inappropriate. In fact, it would be appropriate for anyone seeing this happen, nursing colleagues especially, seeing this happen, to kind of make a complaint against you to your head of department or someone else in the hospital management. So I really think this is something that I think I've seen happen in the UK, and I think this is something that is actually really bad practice, and we should steer away from. And I'd like to just draw a point there on the medical certificate part as well, because obviously in this scenario, the friend called and asked you for a medical certificate. I'm incredibly wary about medical certificates. Even when I'm writing medical certificates totally legitimately for a patient I'm seeing, I do it really sensibly, and I take my time doing it and make sure I'm doing it properly, because in medical certificates, we see quite a few claims for, at least, or problems associated with medical certificates, because often if the employer doesn't like what you've written or takes issue with what you've written, they can put in a complaint against you. So you're bringing in a third party into this equation by nature of the certificate, and they might not like it. And if you're doing medical certificates for family or friends, I think you're getting yourself into real tiger country when it comes to putting yourself at risk. So I would have an absolute no-go policy when it comes to writing medical certificates for family or friends.
So that brings me, that's a good segue actually, Jack, because it brings me to this question that we've been asked, which is, what do you say to someone who asks you to treat them, one of your family members or a colleague? What do you say? Do you have a spiel?
Yeah, I do have a spiel, and I think it's really important because so it depends on how risk averse you are as a doctor, I suppose. I'm quite risk averse when it comes to this kind of thing, especially in my job here at Avan. Having done this, I don't want to end up in any kind of medical problems with the board. So I'm quite risk averse, and I have a policy myself of not prescribing to family, friends or colleagues unless it's an emergency, and I'm quite black and white in that respect. So my spiel is, if someone comes up to me in the corridor at work and asks me for a prescription, and it's happened to me before for things like the oral contraceptive pill, I've run out of the pill, can you just write me a prescription until I've got time to see the GP? Seems innocuous, but I say, I'm really sorry, I don't prescribe for colleagues or friends, simply because I've seen other doctors get in a whole heap of trouble for doing it themselves, and I've seen patients get a whole heap of trouble with their health for doing it. So I just think it's much safer if you make a quick appointment with your GP. And I kind of frame it there that I'm going to get in trouble, your health could end up in trouble, just see your GP and do it properly and appropriately to save us all a heap of bother. And I'm quite black and white on that.
Yeah, and I think the other thing that you can do if you need to have a reason, another reason other than just saying no, I don't do it, is to refer to the code of conduct that we mentioned at the beginning, because then you can say, actually, I'm not allowed to do that under the professional code of conduct, good medical practice that I sign up for essentially when I become a doctor. So you can always blame that, and blaming a third party, if you like, is often a good way of deflecting a request on behalf of or by your family, friends, or staff members. But we do appreciate that it is a difficult situation, and we do appreciate, as we've mentioned before, that being in a rural situation or a very close community can also cause difficulties. And we've certainly had cases of that, of doctors getting themselves into trouble because they are the doctor for a small community where that people in the community are very close, and that's gotten them into difficulties because of that lack of objectivity and the like. So we'll move on to how we can manage some of the risks, and I'd be interested to have your views, actually, if you can put some thoughts into the chat. If the situation is unavoidable, what are some examples of appropriate measures? So whilst you're thinking about that and perhaps putting some ideas in the chat for us, that would be great. I just wanted to discuss with you, Jack, again, when it might be unavoidable. So when is it unavoidable?
Yeah, so there's going to be situations where it's an emergency, and in an emergency, not only is it acceptable, it would be professionally expected of you to help out. So, for example, if someone comes into your surgery in the thongs of severe asthma attack, and it's a family member or a friend, treating them in that situation is obviously the right thing to do, to tide them over until they can get other help. Same with cardiac arrest in the community, anything like anaphylaxis, anything which is an emergency, it would be totally appropriate to treat them in that moment. And then the other settings we've talked about, where you may be the only appropriate doctor available for that time being, whether that's because you're rural or remote, or because you're in a specialist community in a non-remote area, you might be the only person with that skill set to do it. So, and again, you might be, it would be appropriate to do it in that setting.
Yeah, that's a good example. And you know, emergencies are difficult, and we often get queries from doctors around the obligation to treat in an emergency. And certainly, if you're asked to assist in an emergency, you should do that. But you need to be mindful of making sure you only exercise the skills that you have, and you try not to go outside your skills and experience, and because doctors have gotten into trouble for that in the past as well. So that again makes it a little bit tricky, but it does, you know, it does give you a bit of an out. So you work out what first aid you might be able to do in those circumstances.
And I think really importantly, it's about then handing off care again, isn't it, Georgie? So if you're involved in an emergency situation, doing what you can within your scope of practice to help in that situation, and then making sure that you're quickly passing off care as soon as competent help arrives, and if you can, to document or to make clear notes about what happened.
Absolutely. So that brings us into some of the examples of things that you can do to manage the risks where treatment is unavoidable, sorry. And as you mentioned, Jack, appropriate handover. What are some other things that you can do to manage the risks?
So if you are treating someone else in an emergency setting, keeping the actual patient's treating doctor up to date is really important, to make sure you're keeping that continuity of care, and documentation can be really useful there. So make sure that this isn't going to get lost in the system, that you've documented and you've handed over clearly to the treating doctor.
Great. And we've talked about having a good spiel to be able to respond to those sorts of requests, and also in also keeping those social and professional lines really, really clear. I'm just having a look to see about some of the other questions that we've received. Some doctors have said to us, what about the situation where the treatment is inadequate? You know, you have a perception that the treatment's inadequate. You can't just stand by and do nothing. So what could you do in those situations, Jack?
This is a good point, Georgie, because I think, and whoever said this question, I think that's really insightful, because often we probably all had situations where loved ones have been on the receiving end of hospital care or GP care, and we instinctively and absolutely rightly want the best treatment for our loved ones. And and it's not unusual that we might perceive that the treatment they're getting, the run-of-the-mill treatment as we see it, isn't sufficient for our kind of VIP loved one. And I think that's totally rational and normal that you would think that. But it does introduce problems then if you start taking over care alongside the treating doctor, partly because it fragments care, which makes things really difficult, partly because you, as we mentioned right at the beginning, it's really hard to have objectivity. If a loved one's got abdominal pain, you might instinctively want them to have a CT abdomen if it's not indicated, because you're so worried about it. It's hard that kind of emotional overlay blurs the objectivity by which you might make treatment decisions. And so I think it's really important to try and stay away from treating alongside and separately to a treating physician. That's not to say it's not appropriate to have clear discussions with the treating physician and be involved in kind of collaborative care with the treating doctor. And I think that's the way to go about it. I think you're a medical professional, you're bound to have your own opinions, and perfectly rightly, you want to be involved in your loved one's care. But it's probably better to have the conversations with the treating physician or change treating physician if you're unhappy with it, rather than taking over care of the patient, your loved one yourself.
Yeah, that's a really good point. And it is, you can absolutely help your families and members and your friends to negotiate the healthcare system, because you're in it and you know it much better than many of the others. So, discussing with them and with their consent, potentially having a chat with their treating practitioners is fine, just as long as you don't then tip yourself over that boundary. So make sure you do have a very clear line that you draw. But certainly you should not feel prohibited or impeded from helping your family members to negotiate their healthcare, for sure. I think that's a really good point.
And on that note, Georgie, I mean, it calls into question that idea of referring family members as well. So you're wondering whether your family member needs to see a surgeon for abdominal pain or whatever it may be. That idea of referring is, again, a bit of a difficult area, which I kind of view a bit the same as prescribing. It's that taking on the responsibility for care of a loved one. And I think the difficulty with making referrals is very rarely would you, before making the referral, have the means to do a full assessment of the person. If it's a family member, a colleague, or a friend, do a full history, do a full examination to determine if the referral is appropriate, and then to follow up with any communications coming back from the specialist you've referred to, making sure that there's a clear paper trail and documentation. It becomes a real quagmire of discontinuity if you make the referral and then who picks up that information and that follow-up. So again, much better if you can to make sure that your family, friend, colleague is engaging with their GP to make those referrals, rather than taking that on yourself, even if you by your profession are a senior emergency registrar and you know who this person needs to be referred to. It's much more appropriate to get them to do it via their GP.
Absolutely. And we've had cases where, someone asks their colleague to write a referral. So they've decided not to refer themselves, but they ask their colleague to write a referral for them. And off they go, and they say for a pathology or for diagnostic imaging or something. And then if the report comes back and it's not good news, then you're the colleague that needs to break that news to the family, to your friend. And, I think that can make it a very difficult situation. Do you agree, Jack?
Yeah, absolutely. I think you set yourself up for a fail.
Yeah, absolutely. Absolutely. All right. Now, I guess, yes. So I was just about to say, has anyone got any more questions? Because we do have a little bit of time, and we have had someone mention that they feel a bit overwhelmed by the amount of regulatory requirements, politics, legal considerations, and other obligations in medicine. So any good tips or perspectives to not let that take over and lose your will to keep working as a doctor? This is a terrific question. And I'm sorry that at the end of this presentation or towards the end, you feel like that. So Jack, what would be your advice?
Yeah, I think that's a really good point. And I think medicine does feel a bit like that. You go into it feeling you're helping people, but then there's so much over-regulation in medicine that you feel like there's pitfalls waiting for you at every turn. I would say a few things on that. I think that feeling gets a bit better as you go through your career and you get more senior. I don't know how senior the person writing this is, but I think as you become maybe a senior registrar and you go into consultancy, I think that you get a bit more familiar with that territory, and that feeling does go away a little bit. one of my rules, kind of my gut feelings in medicine, is if something's making me feel intrinsically a bit uncomfortable, like if I feel like that just doesn't feel quite right, I will question myself as to, is that something I should be doing? And then another good test alongside that gut feeling test is, would I want this written down on paper and presented to the medical board? So even if you don't know all the regulations and everything, the question still stands there. Would I want this written down? So for example, if you need a blood test done and you went into the emergency department and got a colleague to take your blood test for you, there's something about that makes me feel, oh, is that okay? And then my next point would be, oh, if that was written down on paper and shown to the medical board, do you think they'd think that was good or bad? And probably they think that was bad. So those are my two tests I do to kind of navigate myself through the ethical and medical legal dilemmas in medicine. And you don't need to know all the regulation to do that. But I completely take your point that it is a heavily regulated profession with lots of kind of what seems like traps out there when you're only trying to do the good thing. And again, I would say that in any area of ambiguity, that's partly why you're medical defense organizations there. You are very welcome to call us because that's what we're here to help guide you through.
Yeah, I was just about to say that, at the risk of sounding like I'm giving the marketing plug, that is actually what we're here for. So we do know we do know the law, and we can help you with those regulatory requirements. Absolutely. So give us a call. The other thing, of course, that question has raised is that issue of feeling overwhelmed. And can I just stress again the importance of having your own general practitioner? It's a really important thing, and it might sound, people go, oh, I'm okay. But it's so important. We see lots of doctors who don't have their own practitioner. So if you get into the habit of, and I've heard, and I'm not just saying this as a lawyer, I've heard this from senior practitioners, find a GP that you can see, go and see them for just sort of standard stuff, so that when you are really feeling like you need that support, you have them there and you have that relationship going. So I'd like to really stress that, if I can, to you today. So please don't get a GP if you don't have one. Right. Well, I think that's almost at the end of our time, Jack. There is a question that's completely not related to this topic, which is about revalidation for aging practitioners. Thank you for that question. I can just tell you, just for the moment, the update on that. So the medical board had suggested that doctors over the age of 70 would need to have a health check. And that's one of their components of the professional performance framework that is being very slowly implemented. That's been just put on hold for the time being. They're working through that slowly because a lot of work does need to be done. But the idea behind that is not that it's a revalidation process for practitioners, but much like your driving test, you need to go and have a health check. And it's only if there's some issues and concerns about your ability to practice that the treating practitioner would need to make comment about that to the medical board. So, but that's not imminent at all. It's very slow. It'll be several years down the track before that sort of thing comes in for practitioners of that age. So I hope that I've answered that question for you. So unless anyone's got any further questions, we might just go to the key messages. All right. Oh, here's a question. Here we go. For those of us who've prescribed for family in the past, do these scripts get audited randomly? Should we worry or just turn over a new leaf and do good from here on? That is a perfect question. Jack, what's your thoughts?
I think turning a new leaf is a really good thing. I think it's unlikely that you're going to end up in trouble previously if it was historical, and you haven't ended up in trouble by now. So I wouldn't lose sleep over it particularly. But I like your idea of turning over a new leaf.
Yeah, it's excellent. So I think I hope that we've shown you that this is actually not really a black and white topic. I mean, some practitioners will say to you, so there's a range of views about this. Some practitioners will say, don't do it ever. And they're quite clear about that. Other people have a different view, and this is where it comes down to your own professional and personal ethics about it. So it's not particularly black and white, but the board does say in the code of conduct that you should avoid providing care to those with whom you have a close personal relationship.
I think Sorry, I think one of the most, if you've got a takeaway from this, one of the most useful takeaways, I think, is to have a bit of a spiel ready to go, because when you put on the spot, it can be uncomfortable. But if you've formulated in your mind already what you're going to say, especially if you've got a kind of, I'm not prescribing policy, having that spiel makes it more comfortable and makes you feel much more empowered when that moment does arise.
Yeah, absolutely. And as we've said many times, it's really important to maintain clear boundaries. I think one of the key issues that we've come up with in the past, and the key points that we want to make to our members in this whole area of professionalism, is think about where the boundaries are, have a clear line in your mind. And if you're unsure about where it should be, because ethics is very personal, you need, have a chat to your colleagues about, how they would deal with a situation, because there is a range of views. And some things, you might have that little gut feeling about, and that's a really good sign that, maybe you shouldn't do it. But certainly you should bounce these ideas off your colleagues. I think that's a really good way to deal with them. Jack, is that something that you would do?
Yeah, I think in all walks of medicine, from the clinical to the medical, legal to the ethical, speaking to your colleagues, especially your senior colleagues who have been through all of this for decades longer than us, I think speaking to them about these things can be really helpful as well. Because if Georgie said, like, I may have a policy of not prescribing at all and being quite black and white about it, other clinicians don't have that same black and white and see the shades of grey. And that doesn't necessarily mean that what they're doing is inappropriate. It's a little bit situation specific as well. So I think canvassing those opinions is really important.
Fantastic. So it's all about what it means to be a professional. And on that note, I think that brings us to the end of the scenario, to the session this evening. Thank you very much for all of your comments. Please do the survey. Once you leave this, you can click on the blue link to, or the blue button, I think it is, the blue continue button to do the survey, because we really appreciate your feedback on the session, and also feedback on what topics would be useful for you in the future. So thank you very much for joining us this evening. I hope you have a good rest of the evening. And all I need to do now is to say goodbye, as does Jack.
Take care, guys. Thanks for joining.